Upon completion of this section, attendee will be able to verbalize and troubleshoot common alarms on a ventilator, identify uses for the Passymuir valve, identify the basics of a ventilator circuit, verbalize correct placement of an inline nebulizer treatment, identify where to locate ventilator orders and what to do if the setting on the ventilator does not match. Alarms. We need to respond to the patient immediately with all ventilator alarms by checking the patient first, then the ventilator. When an alarm goes off, there's no way of telling whether it's due to the patient or if it's a problem with the ventilator. Place the patient on their backup ventilator if they are not able to breathe without the ventilator while you troubleshoot. You can always call the DME for the ventilator if you are unable to figure out what the problem is and how to fix it. Patient welfare and safety is our #1 priority. To summarize alarms, and in your Elsevier module, you will notice that they go into alarms in depth. This is just a summary. If you have a low type of an alarm, you have a leak, you are losing air somewhere. The ventilator is not going to tell you where you are losing the air, but it is going to tell you that there is a leak or a low something going on. If it is a high alarm, you have resistance. Something is blocking the airflow, thus increasing airway and lung pressure. The machine needs to protect the lungs, and if there is too much pressure, it can cause some harm. Therefore, there is a high pressure alarm set to prevent this. If you see a low pressure or low minute ventilation alarm going off, it could be that the trach tube cuff has a leak around it, the circuit is disconnected, water trap not threaded on properly or has a crack in it, decannulation, relaxed airway while asleep, or something along that line. Regardless, the first thing we will do is assure the patient's safety, transfer them to the backup ventilator if needed, and then troubleshoot. If it is a high pressure alarm, we have resistance somewhere. For example, the #1 reason why a high pressure alarm is going to go off is your patient coughed, laughed, is straining, or even agitated. This is the most common alarm that goes off because of those reasons. The patient may need to be suctioned. There may be a mucus plug or a trach tube obstruction. It could be time for them to have a nebulizer treatment, so their lungs are bronchospasming and tightening and shutting down. They could have kinked or crimped ventilator tubing. This is caused by a wheelchair running over top of the tubing and blocking the airflow. There could be too much water or condensation in the ventilator tubing, or even in the sensor lines. The PEEP valve could be sticking, or it could be broken, or even water could accumulate in the valve and can cause that valve to stick and make some noise and cause the high pressure alarm to go off. It will also go off if there's airway closure or atelectasis or a pneumonia starting with your patient. Every home will have a test lung in it. It could either be the hard plastic one right here, either a light blue or a clear or white, or it can be a soft-sided one like pictured here, which is like a green or a gray color. The uses for this test lung is, prior to placing a patient on a ventilator, you should hook the circuit up to the test lung and turn on the ventilator. It will compare the set ventilator tidal volume to the exhaled patient tidal volume, and it should be within 50 cc's again on a closed system. This is considered a closed system because it has a constant known volume. If no alarms are going off, then the circuit and the ventilator are ready for the patient to be hooked up. If an alarm does sound with the test lung attached, troubleshoot and the cause prior to attaching the patient to the ventilator. For example, if you have someone that is in a wheelchair and it is time for them to go to bed or they want to take a nap, you need to transfer them over to their bed ventilator. What you need to do first is hook up the test lung, let it run for a few minutes, and then hook the patient up after no alarms have gone off. Likewise, if you are there in the morning and you need to get them out of bed, you need to assure that the wheelchair ventilator is also working. You need to put the test lung on the wheelchair battery, turn it on, and while that is running, you can get the patient prepared. Then you can easily transfer them over to the wheelchair ventilator if no alarms have been going off. The Passymuir valve. When placed on the end of a tracheostomy tube, the Passymuir valve redirects airflow through the vocal cords, mouth, and nose, enabling voice and improved communication. This valve is a one-way valve. It can be placed directly in line of a circuit or at the end of a trach tube. Keep in mind a very important part of this Passymuir valve is if your client has a cuff on their trach, it must be deflated at all times when using the Passymuir valve. Otherwise, the patient will not be able to exhale. You have to assure the patient's ability to exhale because of increased work of breathing when you place one of these valves on the end of their trach. These are also very expensive, so please make sure you take good care of them. Passymuir valves also help with muscle strengthening and can help with weaning and getting the person to be able to breathe through their upper airway when maybe they haven't taken a breath for a long time or at all through that upper airway, and their brain has to be retrained to use that again. If you have a Passymuir in line, it increases the patient's ability to speak complete sentences and also allows them to speak a little bit louder. The airflow from a ventilator will go through the tubes, come up into the patient, be exhaled out, not allowed to exhale through here, therefore has to be exhaled out through the upper airway. Circuitries themselves. The circuit is going to vary with each type of ventilator that is used and also with each patient that has that circuit. There are reusable parts and also disposable parts on a ventilator circuit. Be sure you know which ones you throw away and which ones you keep. You need to follow the care plan to disinfect and reuse those parts. Please be careful not to throw away a reusable part, as the family may not be able to obtain another one for a little while. The changing schedule is going to vary per your patient's care plan. Sometimes we change the circuitry once a month, once every 2 weeks, or even weekly. Unless it is visibly dirty, no longer usable, or they have possibly had an illness that we need to change it a little bit more frequently. Also be aware of the maximum minimum for supplies with your patient. Try to have about 30 days worth of supplies on hand. You never know when something is going to be back ordered or unavailable for a while. A good piece of advice is to not throw the old circuit away prior to assembling a new one. You don't want to have to dig through someone's garbage in order to find all the parts you need to put your circuit back together. Nebulizers. Nebulizers can be placed anywhere on the inspiratory limb. You do not want to place them in front of filters, as the filter will filter out any of the medications that are being delivered. You also need to remove the HME if they are using one while giving the treatment, as it does act as a filter. We want to try to break the circuit the least amount of times as possible. So a good tool out there is a Neb-T adapter. This adapter stays in line with the ventilator circuit, and all you have to do is remove the cap, place the nebulizer treatment inside. It's spring-loaded, opens the circuit, delivers the treatment. You remove the neb cup from there, close it back up again, and it doesn't ever break the circuitry. There was an update in August of 2013 where the advice is to place the neb cup after the humidifier or next to the vent if there is no heated humidifier in line. The reason for this is better medication distribution and 1 to 5 microns for optimal administration of your nebulizer medications. If you do not have a heated humidifier in line, you will place it as close to the ventilator as you can get. So in this photo, you will see you have the ventilator, you have the bacteria filter, you have the nebulizer cup, and then you have the circuitry going to the patient. The other photo shows that the nebulizer is placed after the water trap. So you have the airflow from the ventilator going through the water chamber, coming through the water trap, and then you have the aerosol nebulizer in line to the patient. Aerosolized antibiotics should not be administered with humidified air. Tobramycin is an example of this. Toby is a very sticky medication and likes to adhere to humidification if given in conjunction with each other. We must have a filter on the exhalation side of a two-limb circuit. If there is not one in line, it can cause exhalation valve to become plugged. You want to place the filter prior to treatment and remove it after each treatment. Then you will throw away the filter after 2 treatments because it also becomes gummed up. If you have a single limb circuit, you will not place a filter in line, but may want to wash the exhalation valve for it may become plugged. Physician's orders. Physician's orders can include a lot of different things. It is decided by the mode. The one thing we want to make sure we never do is change ventilator settings unless directed by a physician or respiratory therapist to do so. There are 2 people that will be changing any settings that are ordered in a patient's homes. That is you as the care provider and the DME respiratory therapist that comes. These are all pursuant to orders. This is a sample of a 485 or a care plan for a patient. Somewhere in there is going to be your ventilator orders. On this page, I show in red the ventilator orders for this particular patient. When we're doing our safety checks at the beginning of our shift, we want to assure that our ventilator settings match our 485 or our orders. If they do not match, where can I go to find current settings for my ventilator? We want to look for a new order on the chart. If the order is not there, what is the fastest way to find out the correct orders? Would you contact your clinical manager? Would you contact the physician? Or would you contact the DME company? You would contact the DME company that has provided the ventilator. Remember, I said that there are 2 people that change the ventilator settings. You as the care provider and a DME company respiratory therapist. In your Elsevier module, you will notice that it says several times that if the settings do not match, that you are to change them to what the settings that are ordered and then contact the provider. At Accurate Home Care, we advise that you contact the DME company prior to changing any of the settings. We are not in the home 24 hours, and they may have come after hours and have changed a few things. We need to verify this before we assume that we should go back to the other orders.